2 p.m. so we can begin the meeting. As Mary mentioned, we are on Teams today. And if you have not used it before, there's information in your packet right after the agenda that has some helpful hints. It's very similar, but takes a little bit of getting used to some of the quirks. Next up is roll call. And Mary, will you go ahead with roll call?
Sure, thank you. Calling people alphabetical by first name. So start, and when I call your name, please unmute yourself. Let us know you're here. Christine Eibner.
Here.
Thank you. Eddie Rouser.
Present.
Esther Lucero. Esther. Okay. Hiroshi Nakano.
Here.
Thank you. Kai Young. Kai sent an email. He probably wasn't going to make it today, but we'll try again. Kai? Okay, Kai is absent. Matthew Morrissey.
Here.
Pam McEwen.
Here.
Okay. Rob Murray. Bob, are you here? We will come back to Bob again. I know, I'm not sure about if he's able to come in on Teams. Roger Gantz.
Here.
And Sarah Hewling.
Present.
Thank you. And we'll try Bob again. Bob Murray. Okay, we will mark Bob as absent.
I think he's planning to be here today, so we'll see.
Okay, thanks. All right, back to you, Pam.
Okay, now we're going to handle the minutes. And so just to get everybody on the same page, is there any discussion or any changes to be proposed on the minutes?
Actually, Pam, I'm going to interrupt for just one moment. A Bob has joined, and I'm wondering if that is Bob Murray. Bob, if that's Bob Murray, can you put your hand up and we can promote you? Okay, perhaps not. Sorry, Pam.
That's okay. Back to the minutes. Any discussion on the minutes? Hearing none, would someone like to make a motion to approve?
So moved, Hiroshi.
Okay, thanks, Hiroshi. Is there a second?
Second.
All in favor? Say aye.
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 Any opposed? I think our minutes are approved. Thank you. Next up is public comments. So back to Mary.
All right, thank you, Pam. Since our last meeting, we received 3 public comments in writing, and they're all in your meeting packet. Those are the names of the folks who submitted their comments. And that link, the second bullet, that link will take you to the recording of the oral comments from our last meeting. Public comments, you can always send them in writing to that email box that's listed here. And you also can sign up to give oral public comment at a meeting. You can sign up ahead of time. And then after we go through the folks who have signed up ahead of time, then please put up your hand and you can make comments during this meeting as well. So there's a Teams feature for putting up your hand. Ross, I think the next slide shows us where that is. It's along the top bar. It looks like a little hand if you want to raise your hand. But first, we're going to start with the people who signed up ahead of time. There's a 90-second limit for your comments, so please try to wrap up in that time. Please state your name and your affiliation. So the first person who signed up is Jane Grafton. Jane here.
Hello, my name is Jane Grafton, and I am a member of Whole Washington, and healthcare is a human right. And good afternoon to all of you. I asked the committee to consider dedicating the OIC proviso to an analysis that addresses financing of the universal healthcare system. Specifically, this should outline what the cost will be to consumers. And the concept of consumer includes both the individual and employers. The current average to provide health insurance for employees is 6.9% of gross wages for private companies and 11.2% of gross wages for public employees. In the Washington Health Trust section on employment-based contributions, the outline shows a scheme where employer contributions range from 2% of wages for sole proprietors to 10.5% for large businesses with gross profit of over $3 million. Seattle Times, February 15th business section article outlines the struggle small businesses encounter in providing health insurance. One business currently pays 7.5% of gross profit in health insurance premiums. Under the Washington Health Trust, the cost would be 6.5% payroll assessment. Please ensure that the outcome of the OIC proviso expenditure is an implementable recommendation that the Commission can act upon quickly. Thanks for your consideration.
Thank you, Jane. We are going in order, the order in which folks signed up to speak. And the next person who signed up is Chris Curry. Oh, you're muted, Chris. If you click on the little microphone picture, that will unmute you. You should be able to do that. Let's make sure.
I can bring up the visual, Chris.
Yeah, there's a ribbon across the top with the pictures.
You should be able to see the camera and the mic, and you should be able to click on that.
Are we? Oh, there you go. I think you got it. Oh, try again. I think it was unmuted for a moment.
Maybe, Mary,
maybe we can go to Catherine, and then Chris, we will come back to you. So we will go to Catherine Lewandowski.
Okay, can you hear me okay?
Yep.
All right, thanks. Thank you, members of the FTAC and to the staff for allowing me to give public comments today. My name is Catherine Lewandowski, and I'm a semi-retired registered nurse and the board vice chair of Whole Washington. Thank you for your proposal for using a universal primary care program for our state. This is an idea that has been encouraged by both the past governor of Vermont, the World Health Organization, and other renowned healthcare finance and delivery experts. The WHO has said that offering universal primary care is an excellent stepwise and affordable method to move our state to universal health care. We can all agree that past efforts in healthcare reform have still been unable to reduce the ever-escalating costs of healthcare, both here and in America at large. Adequate primary care offers the benefit of improved health, which decreases overall costs, improves outcomes, improves the health of communities, and increases employee productivity. And it actually makes a lot of sense. It embraces the reality that everyone needs healthcare, and offering full primary care without barriers to access reduces the need for more expensive and emergency and critical health care down the road. According to Healthcare Uncovered, with accessible primary care, people live longer, fewer babies die in the first year of life, quality of life improves, and total costs decrease. When it comes to insurance, we purchase insurance for things that we hope will never happen. We hope we will never be in an auto accident or have our house burned down. We hope to never be in a flood or end up being stranded in another country because our flights have been canceled. So we purchase insurance to protect us in case of disaster. But everyone needs health care, dental care, and vision care, and it can be provided at such a savings over our current healthcare financing model. Those savings can then flow back into the pockets of our citizens and business owners by way of reduced costs for everyone. Thank you.
Thank you, Catherine. Chris, do you want to give it another try? There's a ribbon. There should be a ribbon along the top of your screen, and to the right, there's a little microphone picture. If you click on it, the slash line will go away.
And maybe as a potential alternative, we have a break from 3:40 to 3:50. Chris, if you're willing, I know this is less than ideal to hang on during that break and share your screen. Maybe we could troubleshoot this and you could provide public comment after the break, if that works. I know that that's not ideal, but I don't want to prohibit you from this opportunity.
Or Chris, if you would rather email your comments, we can later in the meeting read them aloud and share them that way.
Okay, am I on now?
Yes. Whoops. Little echo, but we can hear you.
Okay. So you can hear me now?
Yes.
I'm Chris Curry, retired RN.
Whoops.
I'm getting an echo.
Yeah. Whoops. You know, Chris, we will shoot you an email. Maybe you can send the message to us, or we can talk during the break and
Yeah.
talk you through this, because we do want to hear your comments. I think Chris might have dropped off.
Might have worked,
actually
but there
Chris
were
has
two of them,
two
so I
on.
deleted one.
So Chris, could you test your mic again? I think we might have solved the issue.
Yeah, can you hear me now?
That's working
Yeah.
well. Yes.
Yeah, sounds good.
Okay, I don't hear an echo. Okay, here I go. I'm Chris Curry, retired RN and HCFA policy committee member. I'd like to clarify my written comment regarding proposed reimbursement guideline number 6, which I would encourage you to just completely drop from the list. I'm not necessarily opposed to the unspecified quality metrics language. Rather, I'm opposed to the linking of reimbursement system with incentivizing providers. This is just another way of saying value-based payments. Except for fair, consistent, and timely payments, the reimbursement system should have nothing to do with incentivizing providers. In other words, practitioner payment rewards and punishments should not be used as a means of improving patient outcomes. The vast majority of healthcare practitioners will never be incentivized by VBPs. Their incentive arises from seeing their patients get healthier because of their interventions. So the challenge for our universal system is to create a much healthier patient-centered working environment, a healthier patient-centered working environment for fostering the promotion of health and supporting traditional medical ethics instead of reducing the objectives to mathematical productivity formulas. Value-based payments is one piece of the financialization of healthcare that has led directly to extreme levels of professional burnout, moral injury, and physician exodus to Canada. I would also encourage you to read the brand new PNHP report on moral injury at the pnhp.org website. Thank you. Thanks for your patience.
Thank you, Chris. Thank you for your patience as we work out the kinks of everybody getting used to Teams. And thank you for your comment. We'll now go to hands that are up, and I see one hand, and it's Thomas Kennedy. Oops, Thomas, are you? There you are.
Yeah, I think I'm here now. Okay. Hello, my name is Thomas Kennedy, and I'm a volunteer with Whole Washington. I have a few requests today that will hopefully lead to more collaboration between the commission and us in the advocacy space. The first request is about your proposal for universal primary care. Please do not use a private MCO style model for universal primary care. The HCA or some other public corporation is the correct tool to administer this care. Privatization is what got us into this mess, and the fix involves moving away from that model. I also want to echo what Chris said about reimbursements. I thought that was really on point. Second, if you come up with a good proposal for universal primary care and reimbursement, please work with the advocacy movement to help us draft legislation for the 2027 session. I know Whole Washington is happy to work with you on this. Lastly, I want to give a recommendation for a transitional solution that FTAC can investigate with the OAC proviso. Moving away from the MCO model for Medicaid is a fantastic solution that is very likely to save the state money and increase the quality of care. Whole Washington introduced SB 5955 this year to do this, and there is a fiscal note available that FTAC can start from. Short story, it was about $10 million. We would appreciate your assistance crafting a better bill that can get more support across the stakeholder space. Thank you for your work, and I look forward to our continuing collaboration.
Thank you. And another hand up is Mo Brinklund. Mo, you should be able to unmute yourself. We'll give you a moment, and I'm wondering, we can circle back if there's anyone else who would like to raise their hand to make a comment, and then we can go back to Mo's comment. Okay, I'm not seeing any more hands. Mo, if you look along the top of your screen toward the right, there should be a little microphone and it has a line through it. And if you click on it, the line should go away and then we should hear you. That should unmute you.
Our apologies, folks,
Yeah.
for these issues related to transitioning to Teams. We're trying to iron these out in advance, but apologies for some of these hiccups.
Yeah. And Mo, again, during the break, we can connect, or if you want to email your comments, we can read them out loud later in the meeting. That's entirely up to you, how you want to go about that. We do want to hear the comment. All right, I just want to make sure that your microphone, it has been enabled. Okay, I think we will move forward from comments. Mo, we will be in touch before the end of the meeting to try to figure out how to get your comment heard. Thank you very much. We appreciate it. But I think I'm going to move us forward a bit to the next item on the agenda. First of all, thank you everyone for your comments. We always appreciate your comments. Thank you for your patience, as Ross just mentioned, as we sort of work out the kinks of transitioning from Zoom to Teams. We realize not everyone is as familiar with Teams as they are with Zoom. So, we'll iron this out. And we do appreciate everyone's engagement. The next agenda item is mine as well. So rather than hand it back to Pam, I am just going to go right into the work plan update. If we could have the next slide, Ross. I'm going to talk about the work plan status, and I'm going to talk about a new web page we have that is what we're working on. So the next slide. This is the slide that talks a bit about the charge of the Universal Health Care Commission. Sometimes it's good to take a step back and remind ourselves what's in the RCW that created the commission in the first place. As many of you know, there's a two-part charge for the commission. One is to come up with transitional solutions, immediate and impactful changes for healthcare access and delivery system in Washington. As some of our speakers noted, there is a transitional solution discussion later on in this meeting. And there's also universal system design, which is to prepare the state for the creation of a healthcare system, provide coverage for all Washingtons once the necessary federal authority has become available. So sometimes just a reminder of what the legislature has asked the commission to do is helpful. Our next slide. We show this slide a lot of where we are in universal design, where we are in transitional solutions. These pieces that are listed down on the left, the universal system design, those are actually listed out in the RCW as what we need to work through step by step to design this system. So the next slide, Ross, talks a little bit more about where we are right now. The universal design elements right now that reside with FTAC are provider participation and reimbursement and financing. The elements that are being taken on by the commission are enrollment, infrastructure, and government. So governance, excuse me, government, that would be awfully large, just governance. So on today's agenda, we have provider participation and reimbursement, and that is that's the end of our meeting. You'll be hearing from Harrison about the guiding principles, a draft proposal, and also a roadmap. And I have one more slide. This is a new web page. This contains information that has been available before, the completed proposals and some of the, where we are in the work. But sometimes we get a question of, okay, you approved that proposal, but where did it go? And they get included in the legislative report every year. But we also created a what we're working on webpage, just a place to go and to see where we are on things, click on what's been approved. There's nothing here that is brand new. Certainly FTAC and commission members and the advocacy community who follow this closely, this is all information you've seen. We just put it in one spot. Seemed a little more accessible and a little bit easier. And that's the end of my update. I don't know if there's any questions before I turn it over to Pam. Oh, it's all yours, Pam.
Thanks, Mary. I'm going to report on the last commission meeting. As part of my role is as liaison is to attend those meetings and try to communicate back and forth between the two groups. And I certainly invite staff who were in those meetings to weigh in if they have any additions to what I'm reporting on. These meetings are long and complicated, so I want to make sure I get it right. Here's the overview of the agenda. There was, like our meetings, there was a public comment, and then discussion of provider reimbursement, really picking up on our work, talking it through, making suggestions and asking questions about the proposal and guiding principles in the roadmap, the idea of a roadmap for various options. There were presentations on enrollment, infrastructure, and governance, and then discussion on OIC proviso funding. Next slide. Public comment centered on these, which was the critical need for universal care and support for bills that were currently in the legislature. People discussed personal experience, difficulties with the fragmented care system, examples of existing universal systems in the United States, and suggestions to apply the OIC proviso money to studies related to financing a universal system, and encouragement to simplify the enrollment process in commercial and public coverage. There was response to earlier requests to make written comments available to members between meetings. I mean, that's something that we have struggled with a bit, is having the input from the public have the right timing to what we're discussing. Staff is working on that. And then staff talked about creating a SharePoint page to be accessible to workgroup members where we can share public comments so that those things are available to people in real time instead of waiting for the right meeting. Next slide, please. So a lot of discussion about provider reimbursement because we brought them a lot of information to talk about. So they reviewed the draft guiding principles and offered feedback, reflected on the version which is included. That's the version that's included in today's packet. Then there was overview of the provider reimbursement proposal. One of the things that the commission members brought up that was really interesting to me was discussion of primary care, and feeling like that was something that was missing in the work that we brought forward, and the importance not just of primary care, but a really broad understanding of primary care that included community health workers and behavioral health. I kind of on behalf of FTAC, I presented the opportunity to have FTAC drop a roadmap about how we would move in incremental steps towards, a better reimbursement system. That was, I think, pretty enthusiastically accepted. People thought that was a really good idea. And then we had conversations about kind of moving in an incremental way towards a reimbursement system, doing things in a more gradual, incremental way rather than all at once, and with the long-term goal of moving towards a unified system. There was strong support from the committee for that too. So this was really, in my view, kind of the meat of the discussion for me. We're going through these topics with them and kind of their response. For the most part, I felt like there was a lot of alignment and support. I think the most significant thing that came up was the discussion on primary care. Next slide, please. There were two presentations that came forward from the Oregon Universal Health Plan, which noted some large design decisions that had been made. This is really interesting discussion. And then kind of larger structural discussions, which is some of the big design decisions that need to be made, which is, are we talking about a single or multi-payer system, risk-bearing entity, the involvement or non-involvement of insurance carriers? And I think these are huge questions that staff is going to be following up on and will be coming back. And then there was a conversation about proviso funding and ideas for how to spend $250,000. I think in a time of scarce resources, it gets to be a very critical and important discussion about how we would actually use this extra resource that we have access to. And then the commission support for funds. Are there any questions about the meeting or any of the feedback that came back to us, or anything that staff would like to add?
I'd like to jump in with just one thing. A few slides ago, when we were talking about what was in the provider reimbursement proposal, and this is something, there we go, the very bottom bullet. This is something that the commission is aware of, and also we are clarifying as we go forward that this is the commission's intention, that much of what's in this proposal right now, and what much we're talking about, it really represents, a roadmap, interim, incremental changes, not necessarily the final recommendation for the final universal system. That's, I think sometimes we're not quite sure, do we go for the final thing? Do we go for the incremental pieces? And so we are emphasizing that in conversations with the commission so that they are aware that that's what this is, and also confirming that that is what the commission wants to see. I just wanted to call attention to that last one.
Yeah, I really appreciate the emphasis on that, Mary, and I think that's really important. Anything else? I'd like to note that I think Roger and Hiroshi and Bob Murray all listened in on the conversation, and I just want to appreciate their participation. I think it helps as we kind of go back and forth between the two committees. The more we understand their discussions, the better.
And Sarah was there too. Thank you, Sarah.
Oh, yeah.
Great representation.
Sorry, Sarah. And thank you, Ross, for catching that.
Okay, I like my gold star, so it is helpful to attend, especially being a new member. So I don't necessarily need the credit, but that is a bit of my personality. Sorry.
You deserve the gold star. Definitely. Okay. We have a good segue since we finished up talking about the OIC proviso at the commission meeting. I think our next item is coming from Jen Scott, who's going to tell us about the latest on the OIC proviso funding.
Thanks, Pam. Next slide, please. So just a quick reminder of what the OIC proviso details are. As the last slide showed, it's $250,000 of the insurance commissioner's regulatory account to support economic, actuarial, or other modeling related to the design of a universal healthcare system. The funds need to be spent by June 30th, 2027. And the decision was that this would be related to one of the design elements that are still outstanding versus complete. And the final deliverable will provide guidance for making a recommendation, but not the recommendation itself. Next slide, please. So as Pam just described, the commission was asked which of the outstanding design elements they wanted the modeling work to focus on, and the two areas that they came up with were provider reimbursement or financing. Next slide, please. And this was at the last meeting. The potential analyses that had been proposed by FTAC and others were reviewed by the commission, and this is the list of ideas that they looked at. So I'll just quickly walk through these. Hospital global budgets, exploring more aggressive cost containment mechanisms, an inventory of the state's revenue sources, incentives for private employers to opt into a universal system, applying different reimbursement frameworks to the Milliman 2025 analysis, actuarial sensitivity testing of reimbursement scenarios for rural critical access and safety net providers to identify participation and sustainability thresholds, modeling the costs of different administrative structures, potentially drawing from experiences of other states, and modeling the cost of state administered managed fee-for-service Medicaid. Next slide, please. And then the commission also had several additional suggestions to add to the list from their meeting, considering a study that could produce a range of outputs based on the interaction of varied inputs, such as a balance between administrative simplification and financing. So there's kind of an idea about having different dials that could be turned. It could change the inputs. They asked if the focus should be on the entire population or a subpopulation, and then modeling a system similar to a managed fee-for-service Medicaid, but for a broader population, and examining whether cost savings could be used to better fund primary care and behavioral health services, which is a transitional solution idea. Next slide. The next steps are that the staff will synthesize ideas and develop proposals for FTAC and the commission to consider, and we'll also begin starting the contract process. Turn it back to Pam.
Are there any questions or comments on the proviso? Yeah. I think you're on mute. There we go, Sarah.
That last slide, that was what the Universal Commission was asking. Oh, sorry. The one prior to that. So that's sorry.
That was a list of kind of brainstormed ideas, I'd say, that they discussed.
That's one. The commission suggests for the provisos is that came from that last meeting from the whole commission, right?
Right.
Okay, thank you.
Okay, if there are no other questions or comments, we can go on to the next presentation, which is Jane Beyer on the proposed interim solution. I think that Jane is wearing multiple hats today, in addition to being the Senior Policy Advisor for OIC. She's a member of the commission, and she's also a member of the Healthcare Cost Transparency Board. I think Mary Fransen's going to start us out, but then Jane is here to kind of walk us through the proposal on primary care.
Yeah, thank you, Pam. I have one slide, Ross. Oh, no, actually, I think I have two. I'm going to give a little bit of background, and then Jane will give the proposal overview, and then we'll open up to discussion from FTAC members. So the next slide. As we said, this was an idea that was first proposed to the commission during its February meeting as a possible transitional solution. It kind of came up in our conversation, I think, about provider reimbursement. It was not explored in great depth at the commission meeting, but we did talk about it a bit. It's going to get explored a bit more in today's meeting. Just for a little bit of context, the Healthcare Cost Transparency Board, which Pam just mentioned, has set a target of 12% of healthcare expenditures going to primary care in the state of Washington. So today, what we're hoping for from FTAC is some feedback, some questions, help this proposal take shape. And ultimately, it's the commission that will decide whether and how to proceed with this proposal as one of its transitional solutions. So that wraps up my background, and now we go to Jane.
Hi, everybody. So as Pam indicated, I'm Jane Beyer. I'm the Senior Health Policy Advisor at the Office of the Insurance Commissioner. Thanks so much for the opportunity to have a discussion with you today. And many of you, if not all of you, have heard Commissioner Cooter say, I know I want universal health care, and I'm open to ideas around how to get there. And I know that our priority should be primary care and prevention. And leading into that and sort of resulting from those discussions that we were having with her, the concept that we would like to discuss with you today, also knowing the targets that Mary referenced, that the state substantially increased its spending on primary care services. What we wanted to just sort of start a discussion about is a concept of essentially creating a universal primary care system that would be carved out of our traditional health insurance system. And when we think about primary care, I'm not going to go exactly with these bullets. I'm going to go with my notes that I have. So if it looks like I'm looking off to the side, it's because I'm looking at my notes. When we think about primary care, I will say from the perspective of the Office of the Insurance Commissioner, probably the two access issues that we hear about more than anything else is primary care and behavioral health. And what we are looking at here and thinking about when we think about primary care is, as Pam sort of mentioned earlier, integrated primary care and behavioral health, and sort of an advanced primary care model where we could use interdisciplinary care teams, integrating behavioral health, community health workers, and then even thinking about and learning from the experience that Washington State has had with what is now our about 15-year-old direct primary care practice program. And the thought is we would have a single set of consistent quality measures, so we didn't have providers having to respond to 17 different sets of quality measures that were out there. And also looking at measuring to see how a primary care system is doing, measuring things like ED utilization, inpatient admissions, specialty utilization, and just health outcomes, chronic disease outcomes. The thought is this would be prospective subcapitation payments to providers so that they have a reliable source of revenue that's based on the number of folks that have chosen the primary care provider as their primary care practice, with indeed consideration of urban versus rural sort of capacity and resource issues, given how different those healthcare environments are. And then, of course, thinking about considerations of how a carve-out is administered. The assumption is you've got the carve-out outside of the system, but the traditional healthcare system wrapping around it, in essence, and having one of the values of a universal primary care system being reduced administrative burden on providers. And with respect to administration, as we heard in some of the comments, right, is it a state agency that does it? Or is there potentially a contract with a fully transparent entity that's not bearing risk? And the idea, I think, really is to today sort of discuss this idea with you, get your questions and comments with respect to what you as FTAC would think, what are the questions that need to be answered? So defining primary care, what's the payment model? What are the quality measures? How do we coordinate with wraparound health insurance, funding options? And then what kind of modeling would be needed and what kind of assumptions should be made in modeling? And I think the commissioner really sees this concept as a very concrete transitional step that could be a foundation for discussions about pushing out incrementally to a universal healthcare system. So that is the concept that we would love to have a discussion about and get your thoughts and your questions about.
Jane, could I just ask you to repeat your list? I caught most of them.
Yeah.
You were saying today's discussion, defining primary care, payment models, quality metrics, coordinating as a wraparound, and then you had something else. What was it?
So funding, right? And that is going to relate directly to the payment model discussion, of course. Everything relates to funding, doesn't it always? And then if we are going to, if FTAC is interested in bringing its thoughts to the commission, what modeling is needed, what assumptions should be made in modeling, and also what do you think the priority should be for answering these questions and or modeling?
Thank you.
We're really opening it up. Just conceptually, is this a good idea? And then what meat needs to be put on the bones?
I see Sarah's hand up.
The word that got me was prospective versus retrospective. Can you speak to that a little bit?
Yes. So what we are talking about is, rather than providers doing fee-for-service billing, it's almost like the direct primary care model that we have now. We have about, I think it's about 45,000 people in the state who have a direct practice agreement with a primary care provider in the state. And these providers agree not to bill health insurance for what is defined as a set of direct primary care services. And they do that in exchange for a fixed monthly payment from the folks who they're in a direct practice agreement in. And so taking that same concept here, so that a primary care provider, as long as I know how many people are assigned to me and how many people are in my pool, my patient pool, I know how much money I have to work with every month, in essence, because I'm getting a prospective payment every month for each patient that's enrolled with my practice.
Thank you.
Hiroshi, I saw your hand go up a second.
Okay, great. Thanks, Pam. So Jane, generally I like this proposal and wanted to just sort of make a couple of comments on some specific parts of it. One is that the idea of insurance carriers providing supplemental coverage and other services, I think is a great idea and addresses some of the financing issues that we would have to deal with, because that money's kind of already in the system. We're already spending X amount on primary care. It's probably not sufficient for the type of model that we would end up looking at. So there are other areas that we may have to look to supplement that, whether it comes directly out of the state budget or we find a dedicated financing source. I think the commission will need to grapple with that. And maybe in future years, do we look at waivers related to Medicare, Medicaid in a similar way that some of the other states have had in order to pull down federal funding to help augment? And then I like the idea that, you know, we're discussing now provider reimbursement guidelines, right? And I think the utilization of that to help guide us through this will be a nice piece of work coming together. The other comment has to do with the model itself. I like the fact that you pointed out the AIMS Center. I've had experience with that when I was at Valley, and it tends to be really it wasn't 100% across all primary care clinics at Valley, but those that had it, and especially those that didn't have it, wish they had it because because the amount of, especially in South King County, the high percentage of Medicaid, a really high percentage of substance use disorder and just general behavioral health issues that hit the doors were huge. And having that approach, that type of model to integrating primary care and behavioral health was really important to keep a lot of folks from exacerbating and showing up in the emergency room and the hospital.
Okay. And I do one thing that I didn't note is the following. I think it's worth really seriously considering the concept of and the doctrine of corporate practice of medicine in terms of physicians managing the primary care practices. We have seen a lot of aggressive private equity activity in Washington state. And I think the concept here is that it's the clinicians are making the decisions about what services are provided, how big their patient pools are going to be, et cetera, et cetera. And so I'm actually adding to my own list of taking a look at whether the current corporate practice of medicine doctrine in Washington state, which is done via case law, is a sufficient protection or whether it would need to be explicitly built into a model like this.
Yeah, I think that's a really good point. Because if we're going to moving toward a universal package, I think that's a really critical component.
Okay.
Otherwise, we'll just end up, I mean, we're probably going to start off under somewhat of a fragmented system anyway, but the goal at the end is a system where there's a lot more consistency. And if we continue to allow corporate management, then I don't think we ever get to universal coverage.
Mhm.
Yeah.
Thanks.
I think Chris.
Are you referring to me or another
Yeah.
Christine? Or yeah, okay.
You.
Um,
Sorry.
yeah,
Sorry.
no problem.
Sorry, Christine.
So I just wanted to ask what the thought was in terms of how this could providers accept, I guess the state would be paying a fee to the providers on a per capita basis for the patients that selected into that practice. But then one wonders, like, can a patient top that up? And if so, does that create a situation where you have a two-tiered system, or is it possible for the provider to like opt out and just do direct primary care with people who can afford it? And how, I think that incentives there in terms of how the payment is set and whether there's a top-up option would be important to sustainability and whether everyone would be able to get covered, or if this would be something that benefits primarily people who can afford, the higher, like a private school kind of argument, right? With vouchers or something like that.
Yeah, I get what you're saying. I think in the experience, we've had several discussions with DPC providers, and it's really interesting. Their discussions, it's like, no matter how much money my patient has, my job is to do as much as I can within that monthly payment that I'm receiving from folks, because they're really sensitive to the fact that, especially if you have a patient who's in your GP, who has a direct practice agreement, and then who buys a high deductible health plan just as sort of like a catastrophic plan, they're super sensitive to the fact that if they have to send somebody out for specialty care, that's going to be out of pocket cost. But I do think your point is really well taken, is how do you structure it so it doesn't yield a two-tiered system?
I have a question, Jane, because we have one of the things we worked on last year, and I think this was in front of the commission and in front of FTech as well, was reference pricing.
Yep.
And I think both both groups were strong supporters because of the increasing the percentage, changing the balance between specialty hospital care and primary care behavioral medicine.
Yep.
Does this interplay at all with that effort? Have you or Patty thought about that?
I think it could. When you think about, one of the big arguments for the bill that passed, the reference-based pricing bill that passed, was the opportunity that created to increase spending for primary care and behavioral health. In an ideal world, if you have a universal primary care system where people are with a provider for an extended period of time, and given the literature that's out there about effective primary care, reducing ED utilization, reducing inpatient utilization, in an ideal world, we would be able to figure out a way to book some of those savings, maybe not in the first year, right, but in out years. And so the question is, I think, Pam, that you're raising, which is a good question, is as part of a transitional strategy, how do you think about how the non-primary care services are priced so that you can have sustainable financing for primary care?
Yeah, okay. Thank you. It looks like Hiroshi, you had your hand up.
Yeah, I want to go ahead and go to Roger first, since
Okay,
I've already
Roger,
had a chance.
I'm also having my own Teams difficulties where I see Roger's hand, but I don't see Roger's name. So, Roger, please go ahead.
Hi, thank you, Pam. Hi, Jean. So if I might do a quick lead on to my questions, part of our discussion and that, with the Healthcare Cost Transparency Board has been the desire, I think it's universally accepted, around increasing primary care payments. And I would just add that there are strategies now available within the systems we operate to accomplish that. I gave folks a memo that kind of laid out a bit of background on that, strategies to do that. The only reason I'm bringing that up is I think the model we're talking about here has a number of goals. Among those are increases to conceivably to primary care, but those can be accomplished through other vehicles also. So, Jane, let me ask a question. In the model that's been referenced is the AIM model at UW. I think it's been. So one quick question. My understanding with that model, and I'm putting on my Medicaid hat, is that's been really designed to deal with folks who have chronic mental health behavioral presentations, our usual ABC populations. And is the model that you're envisioning here is not necessarily geared for that target population, but in a general application? So that's more of a question.
Yeah, the model is universal. So Raj, if you think about collaborative care model, right, the initial research on it was people with mild to moderate depression and anxiety, and showing really significant improvements in, the PHQ-9 score, for example, for depression. Hiroshi probably knows this more than I do. And there's a full understanding that for somebody with severe mental illness or, very serious substance use disorder, not only would we want to, but we are legally required to, because of our state mental health parity statute, that those services would continue to be available as a supplement to whatever the primary care model is. So it's not, the idea behind this is universal. That's the idea behind it.
Okay. So let me just walk through my other questions. When I think about this, the majority of what folks in our state today, Medicaid is another good example of that, get their health coverage through health carriers, managed care delivery systems. This system, as I understand it, proposes to take out, let's say, primary care and behavioral health, let's use a bucket there, and put those in a separate managed delivery system. The question I guess I would have back for consideration is, would health carriers consider wanting to engage in a delivery system that they did not have, control of the key aspect of that system? So in other words, if you move this out, would carriers still want to participate in this delivery system or not? So I pose that as a question. The other one, Jane, what I'm hearing you say is that has at least been thought about. So we have this benefit and financing. So, and I'm thinking about again, sort of the transitional phase of things. What am I trying to say? The question around, I guess, that needs to be further discussed is how that would be financed.
Right, that's true.
And right, okay. And I just as a sidebar, I get the issue folks have said a long-standing, we get rid of managed care, we got a 10%, 90% medical loss ratio, get rid of their managing it, we got 10% to do with what we want. We could take some of those dollars and expand primary care, right? We've a lot of discussion around it, but my only point of that is that you're eliminating that delivery system. And that's an issue, I think, even in this one, that needs to be thought through some.
You're eliminating which delivery system?
The managed care one.
Oh, I see what you're saying.
Yeah. I mean, one point has been said is, you hear what I'm saying now. So, and then the other piece, what I think I'm kind of hearing you say is, one last one, is in this model, let me just take one last question here, and I'll come back to it. I have somewhat of a concern about bundled payments, and the bundled payment notion is, when all is said and done, that primary care provider is the risk-bearing entity now.
Mm-hmm.
And the question would be, when we think about risk-bearing entities, this might work, in a clinic model, let's say an FQHC, et cetera, where the clinic could have a sufficient patient load to be a risk-bearing entity. The question I would have under these bundled payment models is the ability for that to work for small practitioners, and in particular, its implications that might be in more rural areas where there's an absence of a large clinic delivery system to be able to, sustain that bundled payment model. So I guess the question back is considerations about payment, I think, need to have further discussions.
Right, and I think I said earlier in my introductory comments, recognizing that payment and the approach might look different when you consider urban versus rural. And I think the other really interesting question is, and Raj, we were talking about this back in the 1990s, right? Is do you need some element of risk adjustment, and how do you design risk adjustment so that it isn't, I'm looking for the right word, used the way it's currently being used in the world of Medicare Advantage.
Right. One last thing, I'll be quiet, Jen. I quite agree with it. I'm just saying is, even with risk adjustment, when you have, small numbers, that entity is going to be in a more risk-bearing entity, regardless of what you do with risk adjustment.
That's right. And so, right, let's go back to the days of, in a model like this, does it make more sense to go back? Remember the old Independent Practice Association model?
Mm-hmm.
would the incentives then be for, and let's also remember too, is how you think in this model about the reality that even in rural communities, so many providers are actually employees of hospital systems.
Yeah.
And so how do you
Mhm.
accommodate that?
Yeah.
Mhm.
The rural health clinic model, if you will be. Jane, one last thing, I'll get off of here. You know, we have an opportunity to some respects to do, if you will, kind of a natural experiment with this. This is maybe for consideration. And that natural experiment may be of looking at for SEB and PEB, where you essentially have, you know, half or more of the population in UMP, right? So that's
Uh-huh.
an ASO fee-for-service model where, in theory, the state remains the risk-bearing entity where you could develop these models more fully and see how they work. I'm just making this up, maybe for UMP, and comparing that with those that remain in, you know, either Kaiser or Premier for SEB and PEB. My point there being is you have a conceivably one that's a natural experiment and the ability for the state to implement that since the state administers that healthcare benefit.
Mhm.
Good. Thank you.
All right, Eddie, I see your hand up.
Yeah, I just had a question. When I was thinking about our current state, which is managed care retrospective based PMPMs, and then going to look at moving to a fee for service or moving to a prospective payment system, you know, those are two heavy pivots either way. On the prospective payment system, it's interesting because you talked about risk adjustment, and I think that's kind of the Achilles heel of kind of our current system and that system, as well as what happens there in terms of how those providers use that tool to adjust.
Mhm. Yep, it's important.
So other than an interesting topic of something to consider in our modeling, that's really all I had to say.
Yeah. Sarah?
Thank you. Yeah, I'm just shaking my head a lot. Yes, I hear all this stuff and it's all good information, and I keep going back because I am the rural advocate over here, and I appreciate the clear use of the term rural, and I will always want that somewhere. What I have not seen in my understanding, and I could be missing it, and I would love anybody to let me know if I'm off here. I've seen many models or many discussions of things just like this UW Ames Center collaborative care model being used in an urban setting and being imposed potentially on rural settings. So there was a question about are we going to try to do this over all the population? I mean, yes, ideally, that's what universal means. However, I would advocate for a subpopulation in any modeling or theories we're going to run through the ringer. I don't know if a carve out is the solution as much as trying to implement or pilot or run a scenario through a rural simulation to test it. And then the other part I had about prospective versus retrospective, even if we're going to do prospective, that's, I'm assuming, most likely based on some retrospective information. So
right.
I'm just kind of saying this information because my brain is grinding here, and so I just wanted to put it out there for the group. I don't have a direction with that besides what I just said. So thank you.
So a couple of things. I think your points are really well taken. And I think about things like where there are opportunities to be creative in rural communities. So for example, we have the program, I think it's called the Provider Access Line program, that is staffed by psychiatrists at Children's, at Seattle Children's, so that any primary care doc who has a kid in their office that presents behavioral health challenges can get that consult. And so and then Project Echo, right, Sarah, which is so valuable. And so in a rural community where you don't have the kind of provider supply that you might need to have both of those providers there 40 hours a week, can we be creative about the use of telemedicine, right, about Project Echo to try to adapt? I think that makes a ton of sense. And then your point about if we rely upon retrospective, what's built into retrospective is the underfinancing of primary care. And if the legislature's goal is to spend 12% of health expenditures on primary care, we know that I think the most recent report from the Universal Healthcare Commission was that we're at about 4.5%. So clearly relying exclusively on retrospective is not the answer on this one. So both points well taken.
Thanks. There are lots of hands up, but I think Hiroshi is next.
Yeah, thanks. So just a couple other comments. One is on the concept of risk adjustment. Having worked with a lot of primary care doctors on this, I think one of the other, and understanding the abuses in some cases of that system, I think one of the things that is really useful in terms of how you implement something like that, if you're going to use diagnostic coding or weighted diagnostic coding, is that the intent is really accuracy of diagnosis, right? And that if you're as we roll something like this out, I think that that's an important point, that we're not asking you to game the system. We're actually asking you to do the work that you would normally do. Maybe be a little more accurate and don't stop using unspecified codes, but that's one thing philosophically, right? The other thing is that there is a way to do it without asking or using diagnostic codes. In the old days, I mean, way back to managed care in the 1990s, things were age and gender adjusted.
Right.
That has some of its own issues involved with it. But then the weighting of that system happens centrally rather than asking physicians to do something different, right? The other comment I would make is related that there's been a lot of work done in this area already in the HCA, Dr. Zerzan's multi-payer initiative for several years. And so I would also then encourage the commission. It's not exactly the same as what this proposal is, but there is a lot of good learning that came through that. And just want to make sure we can leverage whatever we can leverage out of that.
Yeah, and I think we were thinking about Healthcare Cost Transparency Board has a primary care advisory committee. So how does that advisory committee get brought in to these discussions that the commission is having? And then also, you're spot on, Hiroshi, that Judy and that group have done a lot of work around sort of the principles of what would a common primary care payment, quote unquote, system look like, and basically taking a hard look at those principles, given the fact that I think there was at least some commitment on behalf of payers, even though we would be carving it out, but at least agreement at a high level about the kinds of principles that should govern a payment methodology. Yep.
Yeah, good. Christine.
Yes, just following up on the issue of risk adjustment, and one thought is possibly using risk corridors as a way of insulating the providers from at least some of the risk. And you can make those corridors tighter for certain types of providers, like rural or small providers, you know, and potentially that would give you the leeway to have a less intensive risk adjustment approach that might be less susceptible to gaming, like this age and gender or something like that. So I don't know, that's just a possibility. Then the other thing I wanted to follow up on is something Roger said about the managed care, like losing the managed care aspect of the primary care provider's role, which I think what he's referring to is like, would that mean that like the primary care provider has an incentive to shunt you off to a specialist, like the moment that something is identified, to avoid keeping that within? I know you said previously that like with high deductible plans, folks might not, some primary care providers would be reluctant to do that, but if everyone's required to have insurance through the ACA and then, or I guess there's no longer an individual mandate, but nevertheless, you could see this kind of behavior, especially if there's not some kind of guardrail against that.
Yep. Good point.
Thanks. Roger, your hand's up again.
Jane, if I could add something back in about reimbursement, we've used the term retrospective, and I'm saying this from an old reimbursement perspective. I would encourage folks not to use that term. And the reason for that is that retrospective reimbursement applies to cost-based reimbursement systems. You set a prospective payment, you make the payment, provider submits, cost report information, and you settle up. Those are retrospective systems. I don't think anybody is talking about that. So I guess I just encourage you not to use that term. Okay. The other interesting one, just back on one of our colleagues' comments about rural health. Let me do a quick landscape on this for us, because there might be some unique opportunities. Jane, I think you and most folks know we got 39 critical access hospitals. Both Medicare and Medicaid recognize those. The majority of those critical access hospitals are part of public hospital districts. The overwhelming majority of those critical access hospitals that are part of public hospital districts also have rural health clinics. So they're all part of that ownership structure. And this model that might be you're talking about conceivably certainly could work in areas where that type of a delivery system is readily available. Now, in more rural areas where it's not the case, obviously, again, that's a separate issue. But there are some interesting building blocks off of that. And I'm going to play this one just a little bit further, because there's CMS has relatively come out more recently with what they call rural emergency hospitals. It's a new delivery system. Legislation was enacted here. There's 43 in the country, one in Idaho. I think there's interest, I believe it's in Soton. But here again, my point is it's a model of a hospital one that can have linkages with the rural health clinic system that this model that you're talking about could be introduced to. So.
That's good. Yeah. And there's also, I know there's interest in the emergency rural hospital designation in Okanagan, just because I spend a lot of time over there.
Yeah, good.
Yeah. Christine. I think you're on mute. There you go.
Oh, I'm sorry. I just didn't lower my hand. Sorry.
Oh, that's your, okay. That's an old hand. Okay. Hiroshi, you have a hand up.
Yeah, thanks. So one other thing that's not outlined directly in this proposal, but it was talked about in the proviso language, and that is the type of modeling I think we might want to consider for this.
Right.
I think that we may want to consider more of an economic analysis or something more like that rather than an actuarial analysis, because I think what we're potentially trying to model here is more looking into the future of what it should look like. And unfortunately, current CPT coding just doesn't capture the types of services that would be included in this, other than, office-based physician work and that type of thing. So having it may miss stuff if you do it from an actuarial point of view.
Mm-hmm. Yep, makes sense. Thank you.
Yeah, I'm gonna jump in line here. So I'm not seeing hands at this moment. A couple things, Jane, I think of. One is that we do have a primary care provider shortage that I think is pretty serious, and
Yep.
that's, it would have to be part of any kind of modeling. And I think it's like chicken and egg. I mean, I don't think you get
Yep.
more primary care providers until you improve payment and you improve working conditions. So that's, anyway, that's something that needs to be thought about. The other is I certainly don't have the experience with payment models that some of my colleagues here have, but I did work a lot with primary care, models of how we did it when I was at Group Health for many years, and we did a lot of different things with primary care because that was supposed to be, what we were really terrific at. And one of the things that I did was involved with was kind of the medical home model that we did, which was really successful from a provider and patient perspective, but was never successful from a financial perspective that was hoped for. And I think that I suspect that maybe because we didn't give it enough time. And I think that is an issue with it. People expect a payback on primary care, but I think it's a payback that can come very slowly.
Right.
Especially if you're opening up primary care services to people who haven't had them or haven't been able to access them.
Right.
And I think that's the first thing the actuaries would tell you. They would expect a lot of pent up demand. So anyway, these are things that just need to be considered.
Yep, you're right.
Sarah, I see your hand.
Thank you. Coming from the rural space and living in one and being an elected official of a public hospital district, I'm very aware of retrospective as a reality. And so I don't think we can't not talk about that. And I also want to speak to understanding the needs of the communities we're trying to serve. And that is the whole of the state. And that's including these attempts to solve problems with resource issues. And I think that's where, when we're looking at, and I don't want to jump ahead, but when we're looking at this potential of funding to run scenarios, I like this idea of the economic lens, which I think would then incorporate some of my research and work around benchmarks and CPT codes that do impact the economics of the whole entity. And I know those are a lot of big words that probably need a lot of drilling down that we don't have time for today. I just wanted to keep the conversation open around the term retrospective. I've seen that, especially with the hospital budget models too, that comes from somewhere, and that's typically retrospective. So I am happy to be corrected on my terms that I use, but that was the intent behind it, is to understand when we look forward, we typically are basing it on something from the past. Thank you.
Are there other questions or comments? See, I promised Jane it would be. Oh, yeah, Roger, one more. Go ahead.
Excuse me. So I'm going to play the devil's advocate a little bit on the issue. I mean, the money will be used how it is, how it needs to be in the proviso. The issue about economic modeling versus actuarial, I have a little bit of a bias. I would argue that we do need actuarial involvement, and I know it's extraordinarily expensive. And the reason for it is these folks are probably in the best situation with the most information to be able to assist in, if we're talking about a bundled rate, how to come up with a reasoned and fair bundled rate. And that's their business, which is different, of course, than if we're trying to look at the outcomes and the impact of this model, which is not within their skill set. But I go back again, and I think we do need their their assistance if you're looking at doing rate restructuring.
Right. And I think the question is there's $250,000 and
I-
what do you spend it on first, right?
Yeah, I know.
I get that.
Okay.
Right.
I know what's
Bob? Bob, do you have your hand up?
Yeah, just to Roger's point, I'm not against using an actuary related to payment models and so on and so forth. I just find that actuaries know more about the technical aspects of reimbursement and less about the policy aspects of reimbursement. I just don't think they have the experience of setting rates and operating a rate setting system. So I think there's a role for an actuary in that context, but I wouldn't make it exclusively, in their realm to advise the state on payment models because they just don't have that expertise. I mean, not many people do. So anyway, I just caution you a little bit on that. And they're also super expensive.
That's a truism.
Okay, any other questions or comments? It's been a great discussion. What are next steps?
So Mary, I'm sort of looking, I think is the idea to have this as an agenda item for the commission meeting on April 30th?
Yes, we are thinking of doing that. So thank you. The FTAC input is very useful. We are figuring out how to best present this to the commission. The next commission meeting is at the end of April. So we actually have a longer time than usual before our next meeting. And in the meantime, the Primary Care Advisory Committee of the Healthcare Cost Transparency Board is meeting. And I don't know that off the top of my head. I know other people on the call know. Before April 30th. Let's just put it that way.
18th.
In April.
Yes.
The 18th. Okay. We are thinking also of, taking the idea to that group as well, maybe seeking input or socializing the idea. I don't know if we quite know what we are doing at the Primary Care Advisory Committee, but the plan is to take this to the commission at the end of April.
Great.
And just for awareness, my understanding of the Primary Care Advisory Committee is more just sharing the idea and encouraging them to attend the Universal Commission meeting on April 30th and to share their public comments and thoughts. There are some primary care docs on there and RPs and those types of folks that we think might, be interested and have some good perspectives to share.
Okay, I think this was a lot of feedback to Shane and to the commission, which I think is everything that we want it to have happen. So we can work on, developing the presentation back to them. And I think if people have additional, they go home and they think of things they needed to say. Mary said, okay, for people to kind of send in additional comments.
The general FTAC mailbox is the best place to send that in, and we can ingest and share those comments, and it's HCA Universal FTAC at hca.wad.gov. We have the chat function disabled, so I can't put it in the chat, but it does appear on an earlier slide.
Okay.
And so you can do the commission or the FTAC, whichever one.
Okay, thanks. And now we're ahead of schedule, which never happens.
Don't jinx us, Pam. Actually, Pam, I was going to jump in for one moment.
Yeah.
I think when Mo dropped off the call and is back. I think maybe she was having connection problems. So, Mo, if you want to make your public comment, can you put your hand up and we can promote you again and maybe do that before we go to the break?
That's a great idea, if she's available.
Let's see. I'm going to allow the mic. And let's see if Mo has a comment for us. No, perhaps not. Don't see her. Okay, well, I'm going to reach out also during the break and see if we can get that comment entered in for this meeting.
Okay.
All right, thank you.
And what do you recommend for break since we are a little ahead of schedule?
What do we have? We planned on 10. Should we do 10, 15 minutes? I don't know what folks want. 10 minutes?
How about 15 minutes?
Okay. Sounds good.
And I will put
right.
that return time in the chat and leave a saver screen on here. So hope folks have a great break and see you in 15 minutes.
All right.
If my math's
Thanks,
right,
everyone.
that's 3:42, I think.
All
Okay,
right.
perfect.
Thanks, everybody.
All right. Thanks.
Hello, Pam.
Hi.
Hey, once we're reconvening, let's give Mo one more try. She
Okay.
and I have exchanged emails. We'll see how Teams does for all of us today. So
Okay. Why
let me
don't
know if
you
you want to do
start
that.
when
Yeah.
we're ready? Why don't you just
Okay.
start to
Yeah, okay.
call on her?
So, Mo, I am going to, oh, your mic has been enabled. Let's see if you can unmute yourself or turn on your camera, and so we can hear your comment. Oh, oops, you know what? I think she dropped again. I think we should, we can go on. Maybe Mo can send us her comments and we can enter them into the record.
Okay.
Okay, thank you.
Okay, I think
All right.
that was the first time we've ever have been ahead of schedule, so that was a new experience. The next topic is, and this is the last topic today, but it's a big one, which is an update on provider reimbursement from Harrison Fontaine. So Harrison, go ahead.
Sure. Good afternoon, everyone. So today we'll be reviewing and getting your input on provider reimbursement. This is work that the work group has been really grappling with over the last few months. We're first going to talk about a few work products and the background for the work. Then we're going to get into some of the specifics. Mo is back. We'll talk about the proposal, get some of your feedback, a few sort of targeted questions there, and then we'll get your thoughts on sort of the outline for the implementation roadmap, which was again offered to the commission, and they accepted that offer, I believe, in the February meeting. Lastly, we'll progress to the guiding principles, which we spent a lot of time on last time, hopefully tying that up, and a few pieces there that also have to do with public comment that we received earlier. And let's go to the next slide. All right, so in terms of the work products that the group is working on relating to provider reimbursement and participation, we have really 3 documents now, ever expanding. The first thing that you're all familiar with is the guiding principles. This is 10 key values that are really supposed to inform the formation of the proposal, but also future regulatory decisions in a universal system. Also, we have the sort of core of it, which is the proposal itself, which is a set of recommendations that could be implemented on a small scale and then broadened. And then lastly, we have the implementation roadmap. So how we're envisioning this, and we'll get your feedback on this a little bit later, is, well, the proposal outlines mechanisms and approaches to broaden those mechanisms. The implementation roadmap is a little bit more specific and a little bit more prescriptive, in that it sort of outlines a few pathways that we could take to incrementally broaden our approach and get closer and closer to a universal system. And let's go to the next slide. Okay, so getting into elements of the proposal itself, currently, based on sort of what we decided in the beginning was in scope and out of scope, we have these sections. We have a background that sort of gives a grounding of why, especially, we talk about transitional solutions more than universal design. We have a summary, an executive summary that sort of ties it all together. And then the core of our proposal is payment mechanisms and approaches. We'll get into these in a second, but as I specified before, payment mechanisms are really sort of the payment schemes themselves, and the phased approaches are how we might expand those in an incremental fashion. Still in development, something we'd like your input on today is elements including oversight and data collection and provider incentives. And then lastly, we have a section that points out a lot of alignment with ongoing work within the agency and within the state more broadly, and other states as well. Let's go to the next slide. Okay, so again, the payment mechanisms and the approaches sort of make the core of the reimbursement proposal, and you can see what this includes here. So under payment mechanisms, we have reference-based pricing, hospital global budgets, aspects of revising the fee schedule, out-of-network price caps, competitive selective contracting, and for future addition, based on conversations today, aspects of this direct universal primary care payment scheme. And then looking at implementation approaches, so ways that we would broaden these payment mechanisms. We can apply payment mechanisms to additional market segments, additional sets of providers, care settings, services, and additional or increasing proportions of the budget. I would also add to this increasing purchasing power, especially when it comes to state purchasing power. So first question to the group is a little bit of a broad one, just wanting to make sure that we have sort of the entire world of these transitional solutions covered. Are there any additional mechanisms or approaches that we as FTAC would suggest adding to this list? The idea here with this proposal is that it really sort of forms and reflects what FTAC's expertise is and all of your ideas. So I see a hand from Hiroshi. Let's go to you first.
Yeah, so question, did you consider bundled payments when you're reviewing different payment mechanisms?
So I believe we do have bundled payments in there in passing, but if you could speak a little bit more to sort of how you would see those as a transitional solution, that would be helpful. And I know others in the group will have thoughts on this as well.
Okay, well, so I'm speaking, a lot of this, what I'm talking about is based on my experience in working with the Medicare bundle payment system. But generically, what I'm thinking about is if we look at ways that we can standardize certain parts of the system in terms of care delivery, and I'm thinking specifically on the specialty side of the world, bundle payments can be a really useful mechanism to look at how do we make sure that utilization of services aren't so broad, you know, in terms of how we standardize care, those types of things. It can be an incentive for provider organizations to work toward, say, a lot of the recommendations that are, I'm forgetting the name of the agency now, but you know, a lot of the work that the state has done to standardize care delivery, you could put a bundle payment to that. So it kind of follows those types of guidelines. I think the other thing too is that from a cost saving point of view, I think there are opportunities. I was working with, I was listening to the conversation at the University of Utah where they built opioid use disorder clinic, and their work with their own health insurance company, they were seeing patients costing like $70,000 a year, and they applied essentially a bundle payment or a standardized approach. They actually didn't get to bundle payment, but they implemented a standardized approach and drove the cost down to $35,000 a year on average. So I think there's usefulness for selected bundle payments approach. So I'm just saying that because I'm not sure at this point if we want to, not use it or not consider it.
I think, as you describe it, I think it would fit well with the current aspects of transitional solutions and mechanisms that we're considering, potentially increments along that pathway. I see a hand from Roger, so let's Roger. Oh, and Roger, I believe you're still on mute. You could hit that slash button on your microphone.
Sorry. An example, just to follow up on this notion of bundled payments, should that ought to be considered, is what the Medicaid program has done for a number of years for maternity services. So they're a bundled payment that the physician gets for the entire birth and delivery process and postpartum care. It is a bundled payment type of a model. So if you want to kind of get a feel for an example that's being used widely today, that would be one that you could reference.
Thank you. Oh, yes, definitely something that we can add into that payment mechanisms aspect. And thank you for the addition. You see. Let's go back to Roger.
All right. I have a question, and it's in these list of items here where we have out of network price caps, and I know that Bob has spoken well on that subject. My question is that topic normally comes up when we're dealing with reference-based pricing. And I would say that, Oregon's adoption of their model for public employees and our state of Washington, the new model has out-of-network caps. My question is that a component that actually belongs under price setting, i.e. reference-based pricing, or is that a notion unto itself? And maybe Bob can speak to that.
Yeah, I can take a quick go at it, and Bob can clean it up for us. I think it would sit separately for the reason that you could imagine setting an out-of-network cap broadly in the commercial market. So, not just talking about PEBSEB, but all commercial payers. But Bob, please clean that up for me.
Yeah, Roger's right. I mean, both Oregon and Washington have a lower amount on reference-based pricing percentage of Medicare for out-of-network. My understanding, talking to folks in Oregon, is that was primarily done to encourage providers to participate in the system and not be out of network. So that, it's certainly a useful thing to incentivize them to be in network. Harrison was correct. My proposing out-of-network pricing would be for the broader commercial market. And the rationale there is, at least in my experience, I think this is also substantiated by Medicare's experience in the MA market. When you have an out-of-network price cap, it basically sets the rate for in-network care, because, for instance, if you had an out-of-network price cap at, well, let's pick 185 or 175 of Medicare, a commercial insurer can say to the provider, look, that's the price that we're negotiating for in-network. If you don't like it, go out of network, and by law, I pay you 175. But what it does also is it removes the counter negotiating leverage that hospitals have traditionally used very effectively, where they, in the absence of an out-of-network cap, they will threaten to go out of network and bill full charges. So their charge could go up, their payment level could go up to 400 or 500% of Medicare. They conceivably can earn more money that way and cost everybody a lot of additional money. So my proposal here is, as Harrison said, to do it broadly across the commercial market, to try to give commercial insurers more leverage to negotiate lower in-network prices. It's kind of a backdoor approach to capping prices without, the ugly arm of government and the government's fingerprints being all over it, if that makes sense.
Let's go back to Roger.
So I thank you, Bob. So my notion here, clarifying this notion of an out-of-network price cap is designed for the fact today where we have managed care delivery systems. So my point is that if in the future there was a decision not to have managed care as a primary delivery system, then this might not be a tool used in that sense. The only entity that providers have to negotiate is the state or single payer. And Bob, my guess would be is this notion of out-of-network price caps, where we tend to think of it with respect to hospitals, and I understand the point that you're making, but that also could be argued for large specialty clinics also, as another example. Is that accurate? Okay.
Yeah. Well, just in general, that would have been my recommendation for the No Surprises Act, that they use basically a reference to Medicare instead of this crazy independent dispute resolution process, which has been a disaster. So there are multiple applications of it. First is in the context of the state and public employee program to try to encourage providers to be in network. Second is my idea of, giving private insurers, more negotiating leverage if you set a cap for out of network, because it really forces them the providers to negotiate around that cap. And then the third is, so it solves the surprise billing issue because it's a hard and fast reference point without getting a lot of people who don't know very much about healthcare arbitrating these things.
Gotcha. And just to clarify, that concept could be applied to more than hospitals. It could be for a variety of providing groups. Okay,
yeah,
gotcha.
Yeah,
gotcha.
exactly. Yeah, I think there's a great application there in the context of no surprises for provider groups like anesthesiologists, radiologists, others that are out of network at a hospital, and they create these surprise bills. So out of network cap can truncate that without fuss and muss of giving it to an independent arbitrator.
Thank you.
Okay. Thank you for the clarifications there. Let me see. And Sarah, I know that you submitted some comments earlier, had a few things to do with primary care and hospital global budgets. I just wanted to know if you had any sort of specific thoughts on aspects that we have up here. Also happy to work with you offline if there's any sort of more text-based changes that you want to work through.
Oh, thank you for that. Yeah, I guess I just would open any questions anybody else might have about that, because I think it was forwarded to the group for consideration. And then I don't have much more to add than what I said there. Yeah, I just appreciate the discussion and hearing what everybody's saying around all this. So
perfect.
Thanks.
We'll keep that in mind as we continue to draft these, and definitely this is a work in progress. That draft in Appendix A is an early draft, and we want it to be reflective of all of FTEC's thinking. And let's go back to Roger. Oh, you're on mute again.
It would be maybe helpful to the commission and others is under implementation approaches of maybe giving examples, additional market segments. So what I'm not asking you to respond to that right now, but kind of an example. What do we mean by that? Mm-hmm. And so I would offer at around each of those.
Yeah, and I think as a work group, we've talked a little bit more specifically about what that could mean. Certainly, the best example is when we talk about expanding from the reference-based pricing approach with PEBSEB. And I think that that sort of more specific example would probably best live in, and this is really a question for the group, I'm currently conceiving it as living in the roadmap document, where this is sort of the more abstract building blocks. That roadmap document would say, if you start with reference-based pricing and you want to expand it by market segment, here's exactly how you would do it. A little bit more prescriptive. But with that said, that's a suggestion that exists in my mind, and I would love FTAC's expertise on it. So let me know if there are any differing opinions. Okay, sounds like we're good there. Before I move on to a few targeted questions about the proposal, I just wanted to know if there were any additional questions about what we have up on the screen here. All right, next slide, please. Okay, so a few questions here. One is that within the public comments, I believe that we heard today, and certainly that we heard in past meetings, is some concern that this proposal that we're drawing up on provider reimbursement focuses really mostly, if not exclusively, on transitional solutions rather than universal design. We know that the commission is aware of that and essentially happy with that. But my question is, essentially, do we want more description as to why we picked that path, why the document really focuses on transitional solutions? Currently in our background, we have a quick allusion to why we sort of picked the route we did, in that I believe this was mostly Bob's writing, in that we have to get our arms around cost containment before we really move forward on a universal system, and that there are lots of levers at the state's control to pull that we might begin to use to get around cost containment. But I wanted to know, sort of broadly from the group, if there are additional reasons, additional thinking as to why this document in particular is focused on transitional solutions, whereas other design elements are more focused on universal design and sort of the end state. Go back to Roger and remember that mute button.
So here's, let me say again, I applaud the fact that there is a discussion in the documents about that we're going to be using transitional solutions. And the one in particular is more to the public in general. As we've talked about before, the other two documents on coverage and benefit design speak to the system, as we envision in the future. The pathway we're taking on reimbursement is transitional. My point being is I think that, particularly to the advocacy community, the more articulate we can be on why we're doing that, I think it lends credibility to the work we're doing. And one other rationale that we could consider putting in here is we can't really model, in my opinion, reimbursement or cost containment strategies until we have a basic design in place, if you will, a benchmark to work from. And I always like to use the example, we've talked about before about global budgeting, and saying, well, here's what the new world will look like with under healthcare reform, using the reimbursement systems we have today, prices and all that aspect in it. And that kind of serves as the benchmark. And then you said, now we're going to introduce, global budgeting, or broadly based, say, reference-based pricing. But the point is, to do the universal system, you got to have those other parameters in place. We don't at this time, so it is another reason why we have to look at this in a more incremental approach. And I'm not sure I'm being as coherent as I should be, but that's the theme.
That makes good sense. And yeah, I think we can add that point of, we have to get the system sort of in place before we envision the rest of it. Makes good sense. And I can work with you to add that in. Let's go to Pam.
Yeah, I was thinking what you said about when we talk about incremental and that we haven't, rather than universal primary care. And I actually think we've talked about transitional solutions all along, because there's so many barriers to moving to a universal design. And what comes to mind is when we talked about the groups that would be captured under a universal system. We knew that Medicare was an issue, that we're very unlikely to get a waiver. I think actually this committee went on record saying it was very unlikely to get a waiver. And then ERISA, and similar complicated issues. So we've been kind of tiptoeing around that all along. And I think sometimes it gets in our way and sometimes it helps us. So I think maybe just kind of putting out a clear, coherent statement might be helpful to kind of, the whole enterprise.
Thanks for that. And just to clarify there, when you say a statement, would that be relating to provider reimbursement or sort of the larger design element enterprise altogether?
Well, let's start with provider reimbursement, and then let's see where that takes us, because it may be something that we want to enlarge.
Sure.
Yeah.
Thank you, Pam.
Thanks.
All right, Sarah, go ahead.
Yeah, I thank you, Pam. That was well said. Kind of what I was thinking without being able to have the words. So again, gold star for you. But I do want to. So I was thinking about the word transitional solutions versus a public comment. I believe her name was Catherine. I wrote down with the whole of Washington. So the advocacy groups, they mentioned the World Health Organization in utilizing a stepwise approach, which makes me, that's an implementation phase. And I get that we were reminded of the legislation, which talks about something more urgently happening versus the long-term system happening. There's this conflict within the legislation, in my opinion, that says do something now, right away. We want solutions now. However, we want it sustainable and universal. So I'm wondering if there's something we could, and I'd be happy to help craft something when I can put my words around it better. This term transitional solutions versus implementation. I know that everybody wants everything yesterday. That's at least how I feel about life. So that's what I was thinking. So Harrison, I don't
Yeah.
know if that's helpful information, but that does loop in some of the public comments and concerns as well. And I do think it's important that we provide clarity around that, even if it isn't clear, if that makes sense.
Yeah. Yeah. Well, I
Thank
mean,
you.
it's certainly still a little foggy to me, and not because of your comments, but just because of the abstractness of it all. I would be happy to work with you on that, and I think that would, I think there are a lot of things that are sort of assumed or implicit in the current proposal, and spelling out, the connections between the different pieces a little bit more, I think would be really helpful, especially so that that document doesn't just read for, subject matter experts and legislators, but also perhaps, the public a little bit more generally. So yes, I will connect with you offline, and we'll go from there. Thank you, Sarah.
Yeah, and if I could jump in for a second, thank you, Sarah, for that comment. And I'm looking for the actual language because when we talk about it internally, hang on just one second. Okay, the RCW says immediate and impactful changes, access and delivery. Sometimes we use the words transitional and interim a little interchangeably internally when we're talking about that part of the RCW. And so probably some clarification is a good idea. We tend to go back and forth between those terms, but what it says is immediate and impactful. You're correct.
Well, and I would just like, because yes, terms matter, and what if you're working with this at a in a instinctual way, you know what it means. But then if you're somebody that just pops in to this public meeting and you see transitional versus, somebody said stepwise approach. Well, stepwise is an implementation process that we're not even implementing anything yet, but yet the legislation says what you just said. And so I think it's fair for ourselves to be able to articulate that somewhere to remind ourselves, as well as the public can then look to it in their efforts. And I heard in our public comments too that people are wanting to be engaged and to help craft some of this as well. And so I would leverage that if that's appropriate somehow. So thank you.
Thank you. Oh, Harrison, it's your turn to be on mute.
I was muted. Before we shift to the next question, any other thoughts or comments on this aspect of transitional solutions versus universal design as it relates to provider reimbursement and design elements more generally? All right, so let's shift to the next one. Can we go back? There we go. So next question. In the current proposal, we don't have a section on this universal direct primary care idea. At least that's what I'm calling it. I'm sure we'll come up with a better name for it eventually. The question is essentially, do we think that idea, that suggestion proposal fits comfortably within this framework where we have payment mechanisms and sort of phased implementation approaches? Or since it is sort of almost a one-shot type deal, at least as currently envisioned, should it more comfortably sit outside of those sections and be a different section of its own where we describe, how the reimbursement scheme would look for that universal direct primary care suggestion that Jane outlined for us earlier? And we definitely hit on several high points of, some specifics there, but generally wondering how folks would suggest fitting that into the current proposal. Any strong thoughts there? Go to Roger first.
Thank you. I think my initial reaction would be that it should be to a degree outside of. I mean, you can sit in whatever the platform. The reason I raise this is because, and it was the point I was trying to make back with Jane, is that this model and moving the payment structure and risk-bearing aspects out of what is our primary delivery system, which is carrier-based. What am I trying to say? It's a major issue. It's a major issue, and I'll go back just to say again, it's not clear to me that if we adopted this, what carriers are going to say otherwise. We can have that but my point is, we've kind of kept away from looking at delivery system issues in what we've been discussing today. So again, what I mean by delivery system, managed care, fee-for-service, and ASO model. So I think we should keep it somewhere in our discussions, but it to a degree, it's broader, in my opinion, and folks that say. Now, having said that, there is a different issue in my view about saying, well, we recognize that we have an access problem in primary care, and we want to look at strategies to increase primary care reimbursement. That's, to a degree, is a separate issue than the model that Jane's talking about. I do quite believe, and I don't know if in our draft documents, we do mention some reference to increasing primary care, behavioral health, and some things like that. I think those are quite appropriate to stay within the document. If I'm making sense, her otherwise is more of a delivery system model aspect. If I'm being clear, I'm trying to say there.
Yeah, and just to make sure I'm following you, are you suggesting that it lives as a separate section within this document?
Sure, wherever
okay.
it's
Great,
sure,
great.
Yeah.
Because yes, I agree with you in that it touches a lot of different design elements all at once. And for that reason, it's kind of hard to fit into this particular box. Let's go to Pam.
Yeah, I think this will build on what Roger said, which is that when we talked with the Universal Healthcare Commission about these proposals, several of the members brought up primary care kind of spontaneously, and community care and behavioral health kind of outside of the proposal for universal primary care, but just the wanting the importance of primary care to be reflected. So I think it's possible to kind of do both, to have a little bit more emphasis on primary care within our draft documents we're working on. And then, as Roger suggested, the universal, the idea about universal primary care kind of stands alone.
Thank you, Pam. And let's go to Bob.
Yeah, I would support Roger's statement to keep it separate. It's kind of an amorphous statement. I really don't know the details of what a universal primary care system would involve. So sounds good, but I would keep it separate. That's all.
Great, thank you. And yes, understanding that as Jane was saying, we have to put some meat on those bones and be a little bit more specific as to what we're envisioning there, and perhaps that's what proviso funding could go to, but to be determined. Hiroshi, I saw your hand was up. Now it's down.
Yeah, I think the comments from Roger, Pam, and Bob, I support all of those, so that it makes sense to me to kind of keep it separate and highlighted.
Great. Okay, thank you. Appreciate the consensus on that one. And let's move to the next slide. Thank you all for your input on that. Okay, just a little orientation as to where we are in the workflow and the timeline here. We've been working on the proposal, the work group has, for a month or two now. The next step for it is for a draft to go in front of the commission. They'll provide additional feedback and direction to FTAC and the work group, and then we'll do another round of that and potentially get a vote and approval on it in about June. We'll see where we get. So I feel like we're doing well on this timeline, and the goal is just to stick to it. And throughout the FTAC work group, we'll continue to revise. I should say one more thing. If any of the FTAC members or perhaps general public have comments on the proposal itself, happy to take those via email just to the FTAC inbox, and we will work on incorporating them as we can. Go to the next slide. Okay, next up, speaking of things that are a little amorphous, is the provider reimbursement roadmap. So this is something that, again, the commission accepted our offer for in the February meeting, and currently we're in the sort of scoping and conception phase. So what we are fairly sure it will include is, again, these mechanisms and implementation approaches that are described in the proposal, but with a little bit more detail and being a little bit more prescriptive. What this could look like is, there are approaches and mechanisms that build on others. And, as Hiroshi, I think, has said in past meetings, there's a sequencing that needs to be considered here. So this would include that in perhaps, a few separate implementation pathways that build and build to ultimately a universal design. Along the way, this could describe additional dependencies, perhaps on other design elements, if any, and some brief descriptions of advantages, disadvantages, other considerations for that sort of more specific phased approach to implementing these mechanisms that we previously described. With all of that noted, I think we're in broad agreement about what that might look like. But I put it to the group if there are additional sections that we'd like included in this document, additional things that we want to be essentially more descriptive on, as this is sort of this more specific document rather than the building block approach that lives in the proposal. And also, I'm seeing our guiding principles as sort of evaluation criteria that as we talk about pros and cons, going back to those guiding principles is one way that we can sort of consider benefits and risks of these strategies. Are there other aspects that we should be evaluating against sort of speaking to as we are describing and adding additional considerations to these, again, sort of separate implementation pathways? Let's go to Roger first. Oh, and Roger, again, the slash button. It's us every time.
Yeah, I'll learn somehow. So can I give you an example to be sure I understand what's being said here? So let's say we have our guiding principles, and we'll say we finalize that. We have we've referred to in the past, let's say a straw proposal, and we'll be looking at that later on. And let me just use two examples, just so I'm clear in my own mind. So one of those makes discussions around hospital global budgeting. And there's one in there that talks about competitive selective contract. I'm just using those as examples. Mm-hmm. So that document may say, here are some thematic areas. And then there would be other documents, whatever form. Let's use global budget and say, here's how we think the pathway to get there for global budgeting, and it would provide more detail and steps, et cetera, how to get there, or competitive selective contracting. That's what you're envisioning?
That is exactly it. Yeah.
Okay.
Thank you for saying it better than I could. Appreciate that. No. Thank you for the clarification. And then let's go to Sarah.
Thank you, Roger. I like what you said. That was helpful for me too, because it's hard to narrow it down when it seems still like big words around reimbursement mechanisms. Thanks. That's helpful. So thank you for that. I do want to highlight that it would be interesting if we can, and I don't know where we're going with this, but the idea of like, let's say the global budget, right? Let's say that, let's run that through, and then that will tease out these mechanisms. And from, again, a rural perspective, throwing out all of the current situation in rural, utilizing these, that approach, understanding the difference of what I call capacity and lower volumes, right? So then making sure those are clearly articulated in that run through to figure out the mechanisms we need to make that, like, let's say, a global budget happen. So if we're going to run it through PEB and SEB, which we do, we have some of that stuff from McMillan's report, right? Can we maybe move forward with? No, I see Roger shaking his head. Anyways, my whole point is, yes, I support what he's saying. And I just want to be clear that we're making sure we are understanding how this is going to impact those different environments. And I know you're going to get sick of me saying rural all the time, but
not at all.
Thank you.
And yeah, I would just add, thank you for that. I think, in some ways the guiding principles are very helpful in that they can be applied to lots of different things. But I think some of your comments have been around having them be a little bit more specific. And I think that this is really where that specificity comes into play, in that, the guiding principles are a bit vague, but as applied to this, they can be quite specific. And I think this is our opportunity to be really clear about potential implications that we really need to flag for, policymakers down the line. Let's go to Roger.
Roger.
You're on mute,
Uh,
Roger. There you go.
Yeah, okay. A thought comes to mind. Through the feedback that we've gotten from the commission and our own thinking, among the reimbursement areas you're going to be talking about in our stop proposal, we make specific references, or will be making or suggesting, around primary care. And I personally applaud that. So I'm offering, should we not do the same, and this is called it rural health and underserved areas, or just rural health, however you want to do that. But for an example, and I know Pam's familiar with this with others, I mean, there's a family of reimbursement signs and designs that Medicare and Medicaid have been working with and continue to work with that might serve us to help us maybe understand a little bit more, but to also include that concept and those a specific pathway trying to speak to rural health. And I see my colleagues nodding ahead. So I'm offering, I'm sure that I have to look back at the document we put together in the past, but it's not there, that we insert it in our straw proposal as something explicit, if I'm making sense.
Yes, I do believe I'm tracking.
Okay.
Would be happy to bounce some text around with you and make sure that that is reflected in the current proposal. Thanks. And let's go to Bob.
Okay, you can hear me, right? I got it. I have two sets of comments. One, if we're talking about a roadmap, I assume that we want to kind of articulate what that roadmap might look like. And just off the top of my head, I think you've got reference-based pricing for the public and state employees. That's a great first start. It's incremental. You can test the concept. You can determine whether there are any unintended consequences. So, look, evaluate it. Did it save money? Yes. Did it disrupt the providers? No. I mean, that's maybe an open question yet, but the preliminary evidence in Oregon is it hasn't been disruptive. Did it reduce access? I mean, have people turned away, state employees, have hospitals turned away and refuse to see them? Those sorts of questions. Did it diminish quality? Did it result in volume increases? Those sorts of things. So evaluate that. Then if it looks like it was a successful program, move to step 2, which I would recommend being out-of-network price caps for all commercial prices. So step outside of just the state and public box and try to do something in terms of cost containment using reference-based pricing for the commercial market. And then same thing, go through the process of evaluating whether it achieved the goals. I think the next stage would be maybe what Vermont is contemplating and using reference-based pricing for all commercial prices, not just out-of-network. And so I think in my mind, this is kind of the incremental approach. It could be accomplished over 2-3 years. And then ultimately, once you've got reference-based pricing for the commercial market, you basically have the rudiments of a rate setting system where you have base rates that are established based on the price caps or the prices being lower than the price caps. And then that calls maybe for an expanded governance structure, like a commission that is a cost commission that would regulate those rates. And they could then fold those rates into a hospital global budget, which would require a waiver to bring in Medicare and Medicaid participation. So again, I don't know the exact time frame for all of this, but in my mind, that's a kind of an example of an incremental strategy. You're building on things, you're evaluating, did it do what you want to do? Did it create harm? And then if not, if they're not problems, then move to the next step. So anyway, that's just kind of my general roadmap. Let me stop there and see if anybody has any comments on that.
Yeah, Bob, I think you described that beautifully, and that certainly would be one sort of pathway within this roadmap, almost exactly as you described it. I see a hand from Roger. Let's go to him.
Yeah. So, Bob, let me say I concur with you, and I think tied to that is kind of an underlying assumption also, maybe implicit or explicit, and that is when we're talking, in my view, about these incremental change structure that we're talking about, we have a platform today through the work that our state does in its purchasing efforts. Medicaid, SEBPEB, of which, the Healthcare Authority and our state has direct handles on. You could argue some of the other models we were talking about of a role for the exchange. Now, I'm using those as examples to what you're suggesting is maybe this is the markets that we play in, Harrison, but those are, if you will, in my mind, pathways that the state could, in theory, with legislative support, get its hands around to move in this incremental direction. So this is more the markets we play rather than the particulars, but it also is part of that incremental pathway notion.
Fantastic. Okay. Thanks for the comments here. I totally agree with what especially the work group members are laying out. So I'll work with the group to go forth and essentially build out something that FTAC can review. Let's move in the interest of time to the next slide.
So Harrison, just very
Sure. Go ahead.
very quickly, the other comment I was going to have is I think I helped draft that principle number 6, but I kind of agree with the person at the beginning. I forgot, Chris, I think, that it talked about the downsides to using pay for performance and value-based payment. So we may want to honor or just recognize and take out, just say that the principle is, the approach needs to try to promote or maintain or promote quality, and not put in this thing about incentives. I've been doing some work recently, kind of evaluating the pay for performance. I know Andy Ryan from Brown. He's done a lot of evaluations of these programs. We started a pay for performance in Maryland in 2009. We're trying to incentivize the hospitals to. I think the jury's out as to whether that does the right thing or not. So I reluctantly, I agree with the comments, and so we may want to debate that or talk about it. Just modifying that principle. That's all.
Certainly, and appreciate you raising that, because that really is essentially where we're heading. Russ, let's actually go to the next slide. Just quick framing. I don't think we're going to get to a vote today, seeing as we have about 30 seconds left. But really, these are the three principles that have been essentially revised since the group last saw the guiding principles. And the one at issue is really the concerns that Bob and Chris have mentioned around. So the current wording is the reimbursement system should incentivize providers to improve the quality of care and reduce unnecessary or harmful care. Essentially, the question is, should this be revised or removed? And if we're revising it, what are we revising it to? Let's take some quick comments, and then I believe we'll be circling back on this for a future meeting. Let's go to Sarah first.
Okay, quickly, it's about accountability. And in rural, we know we don't get the measures stable because of our low volume. So it doesn't, the quality is supposed to be there to show accountability, and we do want quality. So it needs to reflect performance somehow. And then I would want to tie that around, especially with primary care, around the idea of benchmarks and best practices that we have within the clinician, which does tie back to the public comment about letting clinicians be clinicians. So maybe we could look to that type of wording. I don't have it for you right now, but I'm happy to work with you on that.
Thank you. And I just briefly, I think we have another guiding principle that does include accountability. But I think the question is, does it belong best in this one or the other one? But let's go to
I just want to say,
Roger.
Incentivization. I agree with what Bob was saying, that with that other commenter too, that the word incentivize, it might need a different term. Thank you.
Fantastic. And we have 3 hands up. We'll have those be the final 3 hands, and then we'll wrap. Let's go to Roger first.
Yeah, I'll be brief. I agree with what has been said before with respect to draft principle number 6, that the wording there that's in red for now should be removed. So I support that notion. And with respect to draft principle number 1, I'll be careful. I appreciate the work that went into that one, and the acknowledgement, I'm going to be brief on this one again, is that in the future reimbursement systems, we will not discriminate on how we pay providers based upon people's race, their income, or their source of funding, like we do today with Medicare, et cetera, et cetera. So thank you for getting that piece in there. Appreciate it.
And thank you for the important edit. Let's go to Bob.
Yeah, I was just for principle 6, I would just say you can reword it, but I would remove incentivize providers and just say
Fantastic.
the system should promote, maintain or promote high quality and reduced waste, something like that. I don't know, but
okay. Definitely hearing consensus around removing incentive and, sort of how we structure what this is trying to do is maybe an open question. Let's go to Hiroshi last, and then we'll wrap.
Yeah, and so I have a word for you to maybe substitute for incentivize. Maybe you can use the word support providers.
I'm seeing a lot of nods. So maybe that's the direction we will head. But certainly this is something that FTAC will see again before we finalize. Appreciate the careful thinking on this and bringing in and sort of considering grappling with the public comment. I think we're really heading in a great direction here. I'll hand it back to Pam to close us out.
Thank you. Thanks for everyone for the great discussion today on a lot of really complicated topics. It's a great meeting. So we will, as usual, hash this together, develop minutes, and this will go to the commission at I think they're meeting late in April. That gives us time before then to pull together work groups if we need to, or even circulate language to this group that if we want people to look at it again. I think we landed on a really nice consensus. We'll have to confirm that, but I think we did at the very end of the meeting, so that was great. I don't have anything else today. I think everybody's probably ready to go on to their next thing. So thanks everyone so much, and we'll see you in May. What's the date for that?
May 14th.
May 14th. Okay, thanks.
Hey, Pam, thank you for continuing to chair all of this. Much appreciated. Thank you.
Thank you.
That's great.
I echo that, Pam. You're doing fantastic.
Oh, thank you. I appreciate it. I'll take my gold star and head home.
Oh, yeah.
All right.
Gold star. Okay.
Gold stars all around. Thank you all.
All right.
Have a good night.
Thanks, everyone.
Bye.
Bye-bye.